It's an absolute pleasure to be able to speak to the Consortium this morning, and from Vancouver, sunny Vancouver, of course. And yeah, I just wanted to take the time to have a bit of a chat to you about our research coming out of Perth, Australia, which really focuses on how we use exercise as a medicine or as an adjunct therapy for the management of prostate cancer. And I think most importantly, and I think probably the most important question for patients is, what impact can exercise have on survival? Now, this isn't our work. This is from a team out of University of California, San Francisco, who do a lot of epidemiological research and have established through this observational study, so it is just an observational study, but have established a link between exercise and prostate cancer survival. Now, what's really interesting about this is that they looked at actually the quality of the exercise. So as you can see here, men who are participating in over 3 hours of vigorous physical activity after their prostate cancer diagnosis had about a 60% lower risk of prostate cancer mortality. And also about a 50% lower risk of all-cause mortality. And what you can see in these graphs here is that even for the guys that were participating in the same volume of exercise, men who were more vigorous in the blue, in their walking here, actually had a greater protective effect. So this is very early epidemiological research where the field is moving forward. We're actually working on a global trial, designing a global trial at the moment to test this empirically with a randomized control trial in guys with metastatic disease. But it gives us an indication that the quality of exercise is really important in terms of the type of outcomes that we can get. I'm sure this is quite advancing at the moment. There we go. Sorry, there's going to be a delay here. So this is why we really work with our exercise, and using exercise as a medicine, we use a targeted exercise prescription. And what we know from a wealth of exercise science literature is that the specific exercise prescription really dictates the type and the magnitude of physiological adaptations. And a really easy comparison here is to look at the adaptations between aerobic exercise, which is, as you can see on the left there, walking, cycling, jogging, what we typically think of exercise, versus resistance exercise, so lifting the weights. So as you can imagine, the adaptations there are really quite different in terms of the aerobic exercise targeting the cardiovascular system, and resistance exercise targeting the musculoskeletal system. Very important when we're thinking about prostate cancer and the adverse side effects of the treatments. But what we're starting to see throughout the literature, and again building on this wealth of literature in the exercise science field, is that the most significant benefits arise out of a targeted exercise prescription. Something that's individualized, that's monitored, that involves the appropriate exercise selection for the outcomes that you'd like, and of course has the right amount of dosage, or the volume and the intensity, and obviously continually increasing stimulus so the body can adapt. So to move on to our research in exercise and prostate cancer, I've set this up to have a look at a range of different side effects caused by common prostate cancer treatments. Excuse me. And this was one trial that was actually a little bit before my time, but my colleagues Rob Newton and Daniel Galvao led this trial. So a randomized control trial really targeting the effects of that exercise can have on the androgen deprivation associated loss of muscle mass. So we looked at a 3-month, and all our programs are quite similar in terms of the makeup. A 3-month program that was group-based, supervised by accredited exercise physiologists. And as you can see here, these were guys with established toxicity caused by ADT over a fairly significant period of time, an average of about 14 months there. So you'll see here that this graph is set up with the change over that 3-month intervention, with the exercise group in blue and the usual care group in orange. And we're looking at a range of markers here of muscle mass assessed by a DEXA here. So you can see significant differences between the two groups in terms of looking at overall body mass, appendicular lean mass, I should say overall lean mass, appendicular lean mass, and upper and lower body lean mass. So the exercise was able to prompt significant improvements in muscle mass despite the castration levels of testosterone there. And this was able to then restore some of those established toxicities. Obviously, the effect of ADT on bone mass is another concern, and this was a trial that was started a few years ago, and we've just finished off quite recently. We're still analysing the results, which we really tried to target in and have a very specific prescription to target bone mass and minimise the loss of bone, and then to improve some other outcomes. But I'll just talk to you specifically here about bone mineral density. Obviously, with some other side effects there, as you can see with energy deprivation, we're looking at some of the cardiometabolic outcomes, which are quite interesting. And as I say, we'll stay tuned for some of these results. They'll be coming out pretty soon. But in terms of looking at bone mass specifically, this is coming into that targeted exercise prescription. We're really using a type of exercise. It's like a souped-up weight-bearing exercise. So we call it impact exercise, and it's a very specific stimulus to prompt bone remodeling and to try and prevent the accelerated bone loss associated with androgen deprivation therapy. So as you can see in the video, these examples are of different types of exercises, impact exercises, that are increasing in intensity and making greater stimulus for the guys in terms of adaptation to their bone. Now, this is a very sophisticated type of exercise prescription. We screen very heavily to make sure that it's safe for these guys to participate in this, and we monitor this very heavily. So it's definitely individualised. We have robust screening protocols. About a quarter of guys won't actually do this type of exercise, and we need to modify probably about another 15% quite heavily. We can get three-quarters of the guys doing some form of impact exercise. As you can see here. And you can imagine when you first ask these guys to start doing these things, it's a very, these are guys that have been doing it for a long time, and they're nice examples, but we definitely progress the guys slowly. We monitor things in terms of pain in the knees and the back, and ensure that we're progressing things in accordance to symptom response. So these are some preliminary results looking at the comparison between incorporating this modality of exercise to other types of exercise. So this is looking at a change in lumbar spine bone mineral density, and this is only over a 6-month period. Now, I just have to preface this is very preliminary analysis. The analysis are ongoing for our full 1-year data for this, so it's just very early results. But what you'll see here is the guys that, and these were with men who were on established ADT and continuing ADT throughout a 12-month period. And you see the guys with usual care have quite a pronounced loss of bone mineral density in that 3-month period. And what's a little bit surprising to us is that the resistance and aerobic exercise, and this is in line with what our gold standard exercise prescription is for cancer survivors at present, wasn't able to slow that loss of bone at all, really, over that 6-month period. But we incorporated a very specific exercise prescription to target adaptation in bone, that impact exercise. We actually saw a blunting of that loss of bone mineral density over that 6-month period. So it's very exciting in terms of this early results, in terms of what this means in the way that we can target and tailor exercise to really pick out specific side effects that we can start to change. So one of the most pressing issues for men with prostate cancer is the impact of a variety of different treatments on sexual well-being. And the literature has varying results, but I really say that up to about 90% of men with prostate cancer will be concerned by their sexual well-being, or will have some form of sexual dysfunction. And you can see here with the range of side effects that prostate cancer treatments can actually bring about that really lead to this overall decline in sexual dysfunction. And it's really a bit of a laundry list of a lot of direct and also more indirect side effects that contribute to minimising or, I suppose, reducing sexual well-being in these guys. Now, what we've actually proposed and what we're testing empirically now is that exercise is actually an intervention, an innovative intervention that can help to counteract some of these changes and actually improve sexual well-being. So when I talk about this, I'm definitely not saying that exercise is this fantastic panacea, you can solve everything. It's not going to fix nerve damage caused by surgery. There's a lot of things that it's not going to do. But when you look at some of the relatively indirect side effects of prostate cancer that contribute to sexual dysfunction, exercise has established efficacy for counteracting many of those side effects. So I've just talked a little bit about the changes in muscle mass, but the ability of exercise to counteract body feminization, to improve fatigue, to reduce the risk of comorbid conditions that are associated with sexual dysfunction. Obviously to change things mentally for these guys, to minimise depression and anxiety, and then to improve their physical fitness and activity level, what impact exercise can have in terms of masculine self-esteem and quality of life, and how this then feeds into an improved sexual well-being. So we did some very early work and this was a secondary analysis of a previous trial to really understand and get a first idea of can exercise actually have an impact on sexual well-being. And here we specifically looked at sexual activity, and this was a self-report measure of sexual activity, and that's a combination of how sexually active the guys were and how much libido they had. So you can see these were a sample of almost 60 guys who were on ADT, and you can see that about 37% had previous radiation, 40% had surgery previously, and we had this 3-month group-based accredited exercise physiologist supervised program incorporating those two main modalities, resistance exercise and aerobic exercise. And this is really in that theory of counteracting those major side effects in terms of what's happening to contribute to sexual dysfunction. So we saw that exercise really acted to help maintain sexual activity over that 3-month period. And if you look at this table here, the dark bar is at baseline and the grey bar is after the 3-month intervention, and the exercise group over here on the left and the usual care group on the right. And you can see the reduction in the usual care group in terms of their sexual activity and that maintenance in the exercise group. So we saw that exercise helps maintain sexual activity with men who are on ADT, and we saw that difference was really driven by changes in libido. There was a borderline difference in the libido in terms of the guys who had any interest in sex, and certainly a significant difference when we're looking at the proportion of guys that had a major interest in sex. So after that 3-month intervention, none of the guys in the usual care group or the non-exercising group had a high level of libido, but around 17% of the men in the exercise group were able to maintain a high level of libido. So as you can imagine, that's a really positive outcome for the patients. We saw that this was related to the change in quality of life, and we also saw that there were a range of significant improvements in things like body composition, physical fitness and function, and those elements certainly believe played into seeing some of these results. So at the I should say we're to try and get a bit of an understanding of, from the patient's perspective, really what drives this change in libido. We incorporated a mixed method approach and looked at doing some qualitative research with a sample of 18 men. And these were guys, again, who are on ADT. As you can see, it's a different sample there, so more had radiation and only a small proportion had surgery performed. But they've been exercising in our group-based exercise for, on average, about 4.5 months. So we conducted a thematic content analysis using interpretive phenomenological design in order to try and capture the lived experience of the patients. And I think what's interesting, I won't go into too much detail here, is what's interesting is what the patients were actually telling us how exercise helped them and helped their sexual well-being. And as you can see here, that really one of the main themes that emerged was the ability of the structured exercise program to lead to a reinforcement of masculinity, which was associated with this improved sexual well-being. And that was driven by a number of elements that the guys identified. As you can see here, what's happening physiologically, what's happening to their body and how they felt about their body, their vitality levels and how they were less encumbered by fatigue, what's happening mentally in terms of their mood and their positivity, as well as, I suppose, some other elements in terms of their ability to engage and master in a masculine activity and actually to do something to try and help counteract those side effects associated with the prostate cancer treatments. So having a sense of control really allowed them to feel like they were reinforcing their masculinity. So this is some, obviously a really interesting kind of area that we're really discovering. There's a huge amount of patient interest in it, as you can imagine. A lot of the clinicians that we have involved are very excited about these preliminary results, and we're actually currently now running a large randomised controlled trial specifically examining this. So we're looking at about 240 guys over the next 3 or 4 years, and we're seeing can exercise specifically counteract the changes and improve sexual well-being in guys on any form of prostate cancer treatment, and within 6 months of finishing that treatment. So just to give you a very brief overview, we're actually looking at a 3-armed randomised control group design, control trial design. So we've got an exercise-only group who we're going to be exercising for 6 months, and we'll follow them up a year later. And we're actually combining an exercise group with an education program, and this is really to start to look a little bit more about sexual well-being in a holistic manner, in terms of adding in some education about medical management strategies, as well as what's happening in terms of intimacy, some issues around stress management and so on. And this is actually, we've designed in a way that we see could work in terms of translating into practice. So it's a self-management program that's facilitated by the accredited exercise physiologist, and we have specific training programs to upskill these guys to work through these materials, and this is an example of some of the materials there. So it really goes through some basics in terms of stress management and counteracting some of the mental health issues, as well as what's going on with the sexual well-being. You can see we've got a delayed intervention for our control group, so this is our standard design in order to try and maximise adherence and compliance with the usual care group. So we're really excited about this trial, and I think what we're thinking with this is that there's definitely the potential to try and use exercise as an adjunct therapy to pharmacological intervention, as well as psychological intervention, to really try and optimise the management of sexual dysfunction, and to try and hit each of those side effects of prostate cancer treatments using the combination of these potential interventions. So I'm sorry this slide is quite small, but really, using the penile rehabilitation strategies to start to counteract all the very direct side effects of prostate cancer treatments, especially thinking about function and erectile function. Using exercise to counteract those more relatively indirect physical side effects, as well as in enhancing libido, and to counteract that drop in libido associated especially with androgen deprivation therapy. As well as, as we see now, some mental health benefits caused by the exercise treatment as well. And as you can imagine, incorporating some psychological intervention in terms of counteracting the shift to the patient-caregiver dynamic, this altered intimate relationships and some mental health issues, and certainly what's happening with the changes that are caused by some of these treatments in terms of men feeling more emotional and so on. So we're really excited about this direction, and stay tuned for the next couple of years. I think we'll have some exciting results here. So to shift gears a little bit, I think what we really wanted to try and see is, apart from being able to rehabilitate established toxicities, we wanted to have a look at the timing of when exercise could be implemented, and specifically, could we use exercise as a therapy to prevent toxicity? And here we're using it looking at ADT toxicity, okay, so androgen deprivation therapy. So what we did with this trial is actually intervened with exercise immediately when they were first prior to their first injection with ADT. So within 6 days of their first ADT injection, we had them doing a baseline test and getting them exercising. So, and this was the very first time they've had ADT, so ADT-naive patients beforehand. As you can see, just over 60 men, and again looking at over just a 3-month period in this group-based accredited exercise physiologist supervised environment. Now we're looking at a resistance and aerobic exercise intervention to really counteract the changes with the primary outcome there in body composition, what's happening to fat mass and also to lean mass. So if you see with this next slide, when it comes up, there we go. This shows the change over that 3-month intervention in the body composition outcomes. And the first 3 columns here are the outcomes in terms of fat mass. Now what you'll see, the exercise group is in blue and the usual care group's in grey there. So intervening at the same time of the commencement of ADT with exercise actually prevented gains in fat mass. Overall gains in the body, the gains in the trunk adiposity, and an overall percentage fat mass. So not only did it prevent those gains, it actually led to some slight reductions in fat mass. And you can see the magnitude of the difference there in terms of, ranging between 1 kilo to 1.5 kilos, looking at the trunk adiposity and the whole body fat mass. So this is a really exciting result, as we hadn't seen exercise alone being able to affect the ADT-associated increase in fat mass before. So this is really the first literature that's shown that exercise can prevent the gains in fat mass. Now you'll see here with lean mass, with the rapid loss of testosterone and the associated rapid loss of muscle mass with androgen deprivation therapy, the exercise wasn't able to reverse this loss over that initial 3-month period, but it was able to attenuate the loss, such that there was a borderline difference in lean muscle mass over the whole body, and as you can see there, a significant difference in appendicular lean muscle mass. So this is, I think, from the body composition perspective, some very exciting results in how we can blunt and prevent these really initial changes in body composition that can have large long-term effects in terms of a long-term risk of comorbid conditions such as cardiovascular disease and diabetes. So this next slide looks at some of the main outcomes in terms of the interesting findings of, we did a range of other secondary outcomes to try and look at a whole range of different major side effects. So again, the exercise group in blue there, you can see in terms of the fitness level, the strength and the fitness, we saw that the exercise group was able to respond positively to the exercise intervention despite what's happening with their treatment, leading to a significant difference between groups. Mirroring what we're seeing in our other research, we're seeing that the exercise intervention, when it's actually applied immediately at the commencement of ADT, helps to attenuate the loss in sexual functioning. And as you can see, they can't reverse it, but there is a significant difference between the usual care group and the exercise group, so it's minimising that loss. You can see both in fatigue and psychological distress that the exercise group prevented the significant worsening of both those symptoms, which is a really positive finding. And when you think about more what's happening psychosocially with these guys, the exercise guys actually had clinically significant improvements in both mental health and social functioning. So this was another element in terms of help to counteract the psychosocial side effects, especially during that initial phase of prostate cancer treatment. Now we also did a whole, and again it's terrible, too much stuff on this slide, but I just wanted to show that we did a whole kind of blood workup in terms of some of the major side effects with cardiovascular disease risk, lipids and so on. We also looked at bone turnover markers. We didn't really see anything come out of these results over just that 3-month period. It'll be really interesting to see what will happen with the prolonged intervention. But I think importantly what we saw here and what's important out of the bloods is that we saw that similar to previous research that the exercise didn't interfere with the ADT effects on PSA levels or testosterone levels. So we were able to prevent these changes or these toxicities without impacting the efficacy of the androgen deprivation therapy. Now, in terms of what we're doing now, we're really progressing this. I'm sure, there we go. With the current trial that we're running, and it's actually where this is close to closing enrollment, this trial, but looking at I suppose a larger trial, so we're doubling the sample size here. It's about 120, a bit over 120 guys, and looking if we can intervene over that first 6-month period to really try and prevent a lot of these toxicities. And what we're doing specifically with this trial and that longer intervention is we're also including these impact exercises. So we can start to now have a look of, can exercise actually prevent that really rapid change in bone mineral density and bone mass associated with that first initiation of androgen deprivation therapy. So we're really excited how the preliminary results, and I haven't shared them with you here, but the preliminary results from this trial are really quite exciting, and the guys are tolerating it really well, and we're seeing some very promising results. As you can see, just a 2-arm control, a randomized control trial comparing exercise immediately, the initiation of ADT, to a delayed intervention after 6 months, and you can see we have a small follow-up after that as well. So I think shifting, we spent a lot of time talking about, a lot of these guys have localized disease or locally advanced disease. But it's really important that we also have a think about what's happening with the guys who are on long-term ADT, have advanced metastatic disease, and still suffering from many of the side effects of prostate cancer treatment over a longer period of time. So we looked basically in all the research trials that have been in exercise and prostate cancer, and indeed in breast cancer in a lot of the cases as well, patients with advanced metastatic disease and bone metastatic disease are excluded from these trials. So we really have no idea in terms of the safety and efficacy of exercise in these patients. So you can see this is a very small pilot trial in 20 men with bone metastatic disease, and seeing exactly what the safety and efficacy of just resistance exercise, so just lifting weights alone is. And what you can see here, so it's again 3-month intervention, but we're taking an approach where it's a modular resistance exercise intervention. And what I mean by this is that we're actually individualizing the resistance exercise prescription based on every individual person's disease. So we look at the bone scans, we identify exactly where the lesions are, and we prescribe the exercise based on the location of those lesions. So we avoid those areas to maximize safety and still see if we can elicit some sort of physiological adaptations. So you can see here where we've got some broad regions, and we have identified taking a systematic approach in terms of how we intervene with exercise with these guys. So in terms of the safety, and this is really important that we screen them very effectively and we supervise them and really progress them in a highly supervised environment. But we didn't have any adverse events during the actual exercise sessions. You can see there with the attendance rate, these guys are attending at about a similar rate as the guys with localized disease. And I think really importantly, the compliance measure here, this compliance measure of 93% really tells us that the guys were able to complete the exercise prescription that we actually designed and prescribed for them. So there weren't many cases which they had pain or impairment with their function that then limited their ability to adhere to that exercise prescription that we designed. Now, in terms of the tolerability and the exertion associated with the exercise intervention, the target range is between 12 to 16 in this rating of perceived exertion. So the guys were able to exercise at a level that's commensurate with the guys with localized disease. And as you can see here, there was no change in pain medication. There was no real issues in terms of the bone pain resulting from the exercise intervention affecting what they did afterwards. And we screened guys that anybody who had significant bone pain in the first place at baseline wasn't involved with this trial. Okay. So in terms of the the efficacy data, what impact did this have? And this slide, sorry, it's a little bit confusing, but it's looking at the percent difference between the two groups. So one bar is the percent difference between the exercise group and the usual care group, and anything that's positive or in blue, it means it's a favourable change for the exercise group. Anything in red means it's a favourable change for the usual care group. So you can see there was a trend with bone pain to actually be more favourable for the usual care group, non-significant though. And we saw a range of improvements in physical function and fitness, in terms of eliciting over a short period of time with just resistance exercise. That was a really good outcome for us. We saw here with, as you can see, quite a considerable difference between the two groups in terms of their lean muscle mass. And this was very promising in terms of maintaining independence and function as these guys age. And I think really importantly and very excitingly, this physical activity level was an objective measure of physical activity. So it was a 7-day period in which they wore an actigraph, so an accelerometer around their waist that objectively measures their physical activity levels and how intense it was. Basically, they wore that before they started the exercise program or the intervention and after they finished that. So this is a low-intensity physical activity, and what we see with this is that, and what we theorise with this is that the guys who, after they finished the exercise program, they were able to be less encumbered by the disease and able to live a more normal, active lifestyle. I think we can use this as kind of a quasi-objective measure of fatigue as well, seeing that the guys were able to move around a lot more normally in their everyday life. So some really favourable outcomes here in terms of what this means functionally for the guys, and in terms of preventing long-term skeletal complications, these are really favourable results. Just as an aside, we've done some research with ladies with breast cancer and bone metastatic disease as well, and we're seeing some very promising early results. And that's almost like a completely different prescription as well, because the risk of fracture with ladies with breast cancer are almost fourfold compared to the guys with prostate cancer, due to the different types of bone lesions that they have. So that's really interesting, and hopefully that'll be coming out sometime soon. But what we're doing is progressing with this work, and this is a trial that's almost at maturation as well. So we're looking at a larger number of guys with bone metastatic disease. So we're aiming to get about 90 guys, and we're also involving aerobic exercise in this prescription. So you can see it's not just a modular resistance exercise prescription, but it's also a modular aerobic exercise prescription as well as some basic flexibility. And again, based off where those lesions are for men with bone metastatic disease. So it's still just a 3-month intervention, 2-armed randomized controlled trial with an exercise intervention and delayed intervention. So again, some promising early results, but they'll probably be finishing up next year. So I think another really important question in looking at these interventions and efficacy data enrolling us down to clinical practice is a supervised program really important? Because this differs a lot, at least in Australia, to what would be a standard clinical practice in a good setting, where a specialist would recommend someone to be physically active, maybe provide some educational materials. And in this trial, what we did, and this was in guys who were previously treated with ADT and radiation therapy, and you can see 100 men. This was a trial involving both Australia and New Zealand, which we compared the effects of a structured supervised exercise intervention in a clinic for 6 months with a step-down approach to a home-based prescription over the second 6-month period. And we compared that to a control group that was recommended to be physically active and given some physical activity educational material. So you'll see on this next slide the results in terms of what impact this intervention has. First we'll flick over. So again, this slide actually gives you the difference between the two groups and the percent difference, and the dark green is at 6 months, so that's following the structured clinic-based program, and the light green's at 12 months following that home-based program. So over the 12-month period, we saw over the first initial 6-month period, and this is fitness and strength here, as well as lean muscle mass, we saw really pronounced differences between the guys that were involved in a structured program versus those that were involved in just being physically active at home. Those differences you can see, they decreased following that home-based portion, and you can see with the lean muscle mass, it was no longer significant after 6 months. Another really interesting element of this is what was happening in terms of psychosocial adaptations to mental health and social functioning. So after that 6-month period, the guys involved in the clinic-based program had statistically significant and clinically meaningful improvements in those domains, which were not present after that 12-month period, that home-based portion. So it really suggests that there's something going on there of that supervised group-based environment. But what's important about this is that the physical activity levels, the amount of activity these guys were doing, didn't differ between the two groups. But it was all then again to come into that idea of what is this targeted exercise prescription and getting the right dosage of that exercise medicine to really impact the results here. Again, it's not much on that slide that you can actually see, but we looked at a range of different bloods, and there was nothing really in terms of clinically significant, meaningful differences there in terms of what's happening with testosterone and PSA. Again, these were guys that were about 5 years post-diagnosis, so it was a long time ago. But even looking at a range of markers there for cardiovascular disease risk, diabetes disease risk, metabolic syndrome, and so on. So very quickly, I just wanted to have a chat to you about what the patient experience of the exercise program really is, and I think this helps us understand how we can engage guys in long-term exercise behaviours and what it is about this supervised group-based environment that's important to the guys and allows us to realise these benefits. So again, a qualitative design, and this was in guys who were on ADT and were exercising with us for about a 6-month period. So you'll see in this next slide there were three superordinate themes or main themes to emerge from this. And these guys were reporting that they felt the structured exercise program really provided significant health-related benefits. They provided both physical and mental health-related benefits, and that was quite pronounced. And they also provided peer support, both in terms of getting together with a bunch of guys that have a shared experience of prostate cancer, but also a bunch of guys that are about the similar age that have similar stage of life issues. So there was the ability to connect beyond that shared experience of prostate cancer, which was certainly viewed as important for many of the guys. Now, I don't want to say that, so there are lone wolves as well, you know, that peer support wasn't a hugely important thing for many of, you know, not many, for probably about half the guys in terms of ongoing participation. I lied, probably not half. There's definitely a different response in terms of a couple of the guys versus the actual rest of the group there. But I think what's most common throughout everyone is that the role that exercise physiologist has, or in Canada it's probably a kinesiologist or a physiotherapist. So that was really key in terms of shaping the patient's experience of the program and really facilitating those health-related benefits and generating that peer support, that positive group environment. So not only from the professional point of view in terms of the education a person can provide, the exercise physiologist, but also the support they can provide by caring about the well-being of these patients. So I think what this early evidence really shows us, and certainly out of the observation, the anecdotal evidence of watching these guys interact, is that, you know, exercise can definitely, and building on that quantitative data, exercise definitely has an impact on psychosocial well-being for these guys, and we can see that the exercise group certainly can act as a support group, or a support group on steroids, you know, a support group that's tailored for guys, and it really kind of plays on these masculine virtues, right? Gets guys to do stuff, so it's activity-based, allows the guys to come together, casual, positive environment of the gym. Certainly with the Australian guys, there's a lot of humour, there's a lot of friendly banter and competition. And you've got the education and support provided by an exercise physiologist that really instills confidence in these guys and provides a sense of control over what they can do to help counteract those side effects. And as I said before, really helps to extend these social networks. So we've been pushing in Australia to really have exercise being a core component of universal care for all men with prostate cancer. And this is, if you're interested in, you know, if you're in nursing or a psychologist, this is a great little monograph which is published by Prostate Cancer Foundation of Australia, led by Suzanne Chambers, and we incorporated, so we were involved in this to incorporate the exercise as part of this tiered model. So ideally what we'd like to see, and based off this initial research, is that, you know, ideally this exercise can be applied in a supervised prostate cancer specific group-based approach. And by doing that, and by providing these physical and mental health benefits and peer support in a way that actually reinforces masculine self-esteem, this approach may provide an effective avenue for supportive care that is accessed more frequently by guys and has better engagement, even if it's short-term engagement by the men. So I think this is really important in terms of how we can tailor interventions so that they're specifically targeting men themselves. So very quickly, I just want to have a quick chat about what we do in terms of translating this research evidence into practice. So we've worked with a couple of different pharmaceutical companies, and one of them being AbbVie, in terms of creating a patient support program. This is called the MAM plan in Australia, which allows anyone who's being prescribed Leukerin for their androgen deprivation therapy actually gets the ability to participate in this patient supported program, which is subsidised through the pharmaceutical agency. It involves either a face-to-face supervised exercise program, a home-based or a home-based exercise program that's there's peer support, or there's support there by the exercise physiologist. And you can see it's running throughout Australia. It's about 50 sites throughout Australia now. The numbers are probably up to about between 2,500 and 3,000 people now, and we also keen in terms of using the healthcare system in Australia in terms of help to subsidise that. So their competitors, AstraZeneca, have a patient support program now as well, Frank, that incorporates exercise, and we're developing a specific supervised program to accompany the educational resources in this program. So these are two ways that I think they can get at least the pharmaceutical companies engaged in actually providing some of these services to their patients to help prevent the toxicity and restore function. And we run, with the Cancer Council of WA, a program called Life Now, and this is actually available to all cancer survivors, but we do get a proportion of men with prostate cancer involved with this program as well. And really this is it's a model off our randomised control trial, so looking at a 3-month supervised exercise program that's actually administered in the community. So in WA, in Western Australia, we have 12 clinics that run it, and they're just based there, they can be, gyms, fitness centres that are available to the public, that are administered by accredited exercise physiologists that we upskill, that we train specifically and credit them to run this program. So it's good. We've been running over the last 4 years. As you can see, great uptake. It's subsidised through both the Medicare system and Cancer Council of Western Australia, which is philanthropic funding. But it's a model that we're able to intervene with exercise and have good efficacy results in terms of impacting fatigue, distress, quality of life, physical function, and so on. What we're moving to now, and what we've been pushing quite hard recently, is integrating exercise clinics within cancer clinics and cancer centres. And we have a couple of clinics in Perth, one in a private hospital in the cancer centre, and also within a public hospital within the cancer centre there. So we have specific exercise clinics that are available to actually have patients who are going through radiotherapy, primarily for prostate cancer, or chemotherapy for other cancers as well, advanced disease, to exercise during their treatment. And what we see here, this is an example of a new men's health clinic being built in Melbourne at the moment, and they've planned in to have an exercise clinic within their facility. So this is kind of the movement, and what we're pushing for in Australia is having exercise clinics both within the cancer centres and also available after treatment out in the community. What we've also been pushing in Australia is we're a pretty large country with not too many people, so we have a lot of regional and remote areas. So to be able to provide expert support remotely is really important, and we've been partnering with a group out of Melbourne who've developed a website called Prostate, which is a great resource for patients and clinicians to track their progress through prostate cancer. And what we're actually integrating into this is online consultations with prostate cancer trained exercise physiology experts. So this allows patients to access expertise, and it also allows for home-based programs to be supervised through local exercise physiologists or personal trainers by experts in the area. Just really quickly, I just wanted to, after I'm harping on about exercise, just let you know what the specific guidelines are, and these are really driven from the American College of Sports Medicine, but have been reinforced by the American Cancer Society and also the National Comprehensive Cancer Network. And really the message here is that exercise is safe during and after treatments if it's prescribed and supervised effectively. Certainly patients need to avoid inactivity regardless of what kind of treatments they're going on. And the general message is that some exercise is better than none, more is better than less. However, if you're trying to look at significant health benefits, the recommendations are that aerobic exercise, you want to be trying, and that's the walking, running and jogging and so on, you want to be trying to attain a goal of 150 minutes of moderate intensity aerobic exercise each week. So brisk walk at least 30 minutes a day on 5 days a week. And also for the resistance exercise, hugely important for men with prostate cancer, but so often overlooked in terms of the exercise recommendations. So this is the lifting weights, right? And so you're going to be trying to do 2 to 3 resistance exercise sessions each week. It's at a moderate intensity, so it's hard work, and it's involving the major muscle groups in the upper and lower body. So this is a lofty goal for people who've never been exercising before, but I think that it's something that you progress slowly towards, and it's an individual progression. And the biggest thing is that intensity is individual. So what's very hard for someone could be very easy for someone else. So we can very much so individualise this to ensure that there's safe, easy progression, or not easy, but safe, steady progression up to these guidelines. And certainly refer to a certified exercise physiologist or accredited, I'm not sure what the accredited physiotherapists are here, or kinesiologists, but certainly seeing the right exercise professional is important. So I think just really briefly, I just want to highlight the role of the clinician in actually facilitating the patient's engagement with exercise. And we certainly see that the involvement of the specialists and the support staff are critical. It certainly brings a lot of clout with that prescription if a patient is actually getting a recommendation and a referral to a program. And what we're seeing now that while the provision of educational materials is good, and while the recommendation to be physically active is very important, sometimes it's not enough to mimic the actual efficacy data that we're seeing in these supervised trials. So it's really important that that we work as a field to try and implement these programs that are available for all patients with cancer. So I think, just to wrap up all this research, what we really see that exercise is a medicine, and indeed what we know in men with prostate cancer, it certainly offers the greatest potential as an adjunct therapy to reverse treatment-related side effects and improve the quality of life in men with prostate cancer. And I think we'll see in the next 5, 10, 15 years what impact exercise can have on prostate cancer progression and survival in highly controlled clinical trials. So just want to acknowledge the fantastic research team that I'm fortunate enough to work with in Australia and throughout Australia. We have a really fantastic multidisciplinary team of exercise physiologists, of clinicians, urologists, radiation oncologists, medical oncologists, health psychologists, nursing and so on. So we're really fortunate to work in a great multidisciplinary team, and I'd certainly like to acknowledge their contribution towards all this work. So thank you very much. Hopefully there's a little bit of time for questions if anyone has any.